Here we're looking at an orthokeratology case, and doctor's two questions are whether there's anything we can do about the residual astigmatism in the post-wear refraction, and also whether the treatment zones look like they are sufficient. I'll tackle the second question first because I think that one's a little bit easier. As far as sufficient, I'm not sure if you specifically mean is it large enough or is it well defined enough or is there enough treatment? The way I see it, I think the size of the treatment zone is fine. If the patient's not complaining of any glare or halos, then I definitely would leave it alone, and I don't think that was one of the patient's complaints. So as far as the size of the treatment zone, it looks great. The definition of the treatment zone, it's not super sharp in the left eye specifically, but this was not a very high prescription to begin with. I think it's a little bit over -2. And so with the lower amounts of correction, sometimes we don't get that very, very sharp demarcation between the reverse curve and the alignment curve of the lens. And I think that's okay. It doesn't really affect quality of vision, I think, too much. If I bring up the lenses, right now the junctions are blended. The check box is off. If you were to check the box, it does give you a sharper return, and because the junction is not blended anymore. And sometimes it does give you on the topography a slightly sharper looking ring, but again, I think that's more to do with how we like the appearance of the topography and not necessarily for better patient vision. So as far as the sufficiency of the treatment zone, I think it does look fine. Now if we bring up the lenses, the other question was, is there anything we can do to help the patient with residual astigmatism? And if we look at the topography here, it's fairly spherical, a little bit of cylinder, and then the patient's spectacle refraction was fairly spherical, minimal cylinder, but in the post-wear refraction, I think the patient refracted out with somewhere around 3/4 of a diopter of astigmatism. And if we just look real quick here in the spectral refraction, it's at axis 70, and then according to Wave, the corneal toricity is in axis 140. So even though everything is fairly spherical, the patient does have internal astigmatism. Lenticular astigmatism is not correctable with Wave lenses because, or any kind of ortho-K really, because that's only done at the cornea, and there's no changes induced on the lens, obviously. Now, there is possibly a way to induce corneal toricity, and if we take a spherical cornea and turn it into a toric cornea, that's an exact opposite orientation to the patient's lenticular astigmatism, then theoretically the two cancel out. However, this is kind of difficult to do. I will give you a link to a video where I discuss a case with more specifics. There's an example of how to create such a lens, but then I also give you a list of reasons why maybe we shouldn't do that and why it may not work. But I will provide you that link just for information. So as far as the residual astigmatism in the right eye and the left eye too, you can see the same thing. Wave shows about a diopter in axis 162. The patient has in their spectacle refraction half a diopter, axis 135. So there's a fair amount of astigmatism that is internal, it's not on the cornea, and that is very difficult to mold out with ortho-K lenses because what we have to do is actually mold in additional cylinder to cancel out what's there internally. So that said, is there anything we can do to improve this patient's vision? I'm going to minimize the lenses here. And if we look back at the topographies, what I noticed looking through also some of the other topographies that were submitted is this patient's tear film isn't that great. I noticed that at each session, quite a few pictures were taken of each eye, and about half of them, the Meyers, were too distorted for Wave to really process. So my recommendation is to figure out why this patient's tear film is not quite as in good quality as we would like. Is it dry eye? Is it lid disease, meibomian gland dysfunction, blepharitis, whatever it may be? And I would treat that pretty aggressively. Especially with corneal molding, we do want to have a good stable tear film that enhances their treatment. I also think it enhances their post-wear vision. You may not necessarily reduce the amount of cylinder you're getting in your over-refractions, but I think the patient's quality of vision overall may pick up a little bit, and that may be enough to kind of get the patient by. So to wrap up, I think your treatment zones look fine in both eyes. If you wanted to remove the blending from the junctions, it might look a little bit better, but I'm really not sure if it's going to give you any visual improvement. And then as far as reducing the post-wear cylinder component of the patient's refraction, I will provide you a link to a case where I discussed some theory on that. But overall, I think the best way to improve this patient's vision is probably to go after that tear film and try to get it as clean and stable as possible. So I hope this helps, and thanks for watching.